So I'll continue now with some abstracts looking at management of constipation, which is certainly a common clinical challenge in our clinics. This table I took from a recent systematic review published through the American College of Gastroenterology, looking at available therapies for chronic idiopathic constipation, both their strength of recommendation in favor of their use and the evidence in support of their efficacy. And you can see from the list we have a number of strategies available to us, including fiber supplementation, PEG 3350, lactulose, sodium picosulfate, and bisacodyl, as well as Prucalopride, Linaclotide in Canada, and also in the United States, lubiprostone. And for some patients with pelvic floor dyssynergia, and depending again on availability, biofeedback is also an available strategy. Now, these are all useful parts of our therapeutic armamentarium. We'll look at some data, new data on Prucalopride. Prucalopride, of course, in Canada is approved only for treatment of women with chronic idiopathic constipation, largely related to the strength of data and the predominant enrollment of females in clinical trials. So the first abstract I'd like to show you is this one, looking at a randomized controlled trial of use of Prucalopride in men with chronic constipation. This is a phase 3 clinical trial. It enrolled 374 adult men with chronic constipation, defined, as you can see, from by having no more than 2 complete spontaneous bowel movements per week. And this CSBM is now a common metric in clinical trials of constipation. They were randomized to be treated for 12 weeks with either the active intervention, which is Prucalopride, 2 milligrams daily. The dose can be reduced in men over the age of 65, or placebo. So this was a double-blind trial. And their primary endpoint was the proportion of subjects in each arm who achieved at least 3 complete spontaneous bowel movements per week over a 12-week follow-up. And you can see that the results were highly clinically and statistically significant, that 38% versus 18% met that goal. So I think from this trial, certainly, we have good evidence that Prucalopride can be an effective therapy not only for women, but also for men with chronic constipation. There were some secondary endpoints looking at the proportion of subjects who had an increase of at least 1 complete spontaneous bowel movement per week, or of 1 simply spontaneous bowel movement per week, and you can see that those also reached statistical, that second endpoint also reached statistical significance. And they also looked at safety. Some common adverse events are listed here on this slide. Not surprisingly, given in the mechanism of action of Prucalopride, you see slightly higher risks of diarrhea in the active therapy arm, but really no new safety signal among men in this clinical trial. So conclusion again would be that Prucalopride is effective and has a safety profile, no new signals among men with chronic constipation. So another agent we have available for us in Canada for treating chronic constipation is, of course, Linaclotide. And I recall one of the pivotal clinical trials, which was published in the New England Journal of Medicine in 2011, looking at a 12-week treatment with Linaclotide for patients with chronic idiopathic constipation. Again, the endpoint on the y-axis in this graph is the number of weekly complete spontaneous bowel movements. And you can see while on therapy, there was a clinically and statistically significant increase in this metric. And after withdrawal of therapy at week 12, there's a quick return to baseline in the patients who were re-randomized to placebo. So clearly an important effect size among patients who received therapy, but an effect which was limited to the duration of therapy with the resolution upon treatment withdrawal. And there was no difference between the two treatment arms in this clinical trial, 145 versus 290 micrograms per day. And so for this indication, it's the 145 microgram dose which has been approved. So presented at this meeting is a phase 3 trial looking at patients with chronic idiopathic constipation, but specifically with prominent bloating symptoms. And I think all of us would agree in practice that these are challenging patients to treat. So we know that IBS is not simply a colonic disorder, that patients with IBS often have other functional disorders in conjunction and will fulfill other diagnostic criteria for other functional disorders. So in this clinical trial, the subjects with chronic idiopathic constipation and prominent bloating were randomized to either treatment or placebo with the 2 doses that we've mentioned of Linaclotide, 145 or 290 micrograms per day. and throughout the trial had a dyspepsia scoring system applied, in this case the Nepean Dyspepsia Index. Now this tool measures the frequency, intensity, and quote, bothersomeness of 15 individual dyspepsia symptoms, but also includes within it the 4 key symptoms that fulfill Rome criteria for functional dyspepsia. So they had a population of 483 subjects who went into this trial who had constipation as well as prominent bloating, and essentially found that the reductions in each individual symptom for dyspepsia were greater in the active therapy arm compared to placebo, and specifically among those 4 key symptoms that are relevant to Rome diagnostic criteria for functional dyspepsia. There was a statistically significant reduction in 3 of those 4 Rome criteria for functional dyspepsia. So the conclusion of this trial was that linaclotide was effective, as we've seen before, not only for treatment of constipation, but also for relief of dyspepsia among the constipated patients who have prominent bloating. So I think this, again, gives us some confidence in using this agent in our clinical practice. Well, if we move from functional constipation to IBS with constipation, now, many of us in clinical practice don't discriminate neatly between these 2 Rome diagnoses, but to remind you that technically they share a lot of common diagnostic criteria, such as the duration of symptoms, the chronicity, the description of constipation in terms of stool form and difficulties with stool passage. But IBS-C moves a little further to comment on abdominal pain or discomfort. So patients with IBS-C have not only the features of constipation, but also pain or discomfort, and that pain or discomfort relates to bowel movements often relieved by passage of stool, or at least associated with passage of stool. So if you look at linaclotide for treatment of IBS with constipation, IBS-C, this is one of the pivotal clinical trials, a 12-week trial essentially showing efficacy of linaclotide for relief of abdominal pain and also for changing the frequency of complete spontaneous bowel movements. So both of these key metrics among our patients with IBS-C improved with treatment with linaclotide over 12 weeks. And again, when treatment was withdrawn at the end of 12 weeks, certainly the bowel frequency reverted quickly back to baseline, although there was some residual effect in terms of pain relief after treatment withdrawal. This is another pivotal clinical trial which was published 2 years ago by Bill Shea et al. This was in fact, a 26-week randomized controlled trial comparing linaclotide to placebo, although the primary endpoint was actually assessed at 12 weeks, and this was mandated by FDA. It's a combination of abdominal pain relief and an increase in the frequency of complete spontaneous bowel movements. And when you put those 2 metrics together on the right side of this panel, you can show that there was a clinically and statistically significant difference in favor of linaclotide therapy. And I should note that the effective dose for treatment of IBS-C with linaclotide is 290 micrograms per day, not the 145 micrograms per day approved for treatment of chronic constipation. So with that as backdrop, we saw at ACG a presentation of additional data from the follow-up phase of that second pivotal induction trial. So these were patients with Rome 2 IBS-C who had been randomized in that 26-week trial to treatment with linaclotide, 290 micrograms daily or placebo. After they completed that blinded trial, they were eligible to roll into an 18-month open-label follow-up study. And data from that follow-up study which are presented at ACG. So in fact, over 500 subjects entered that long-term study. And this analysis looked at the patients specifically who developed diarrhea as an adverse event. So about 1/3 of the patients throughout that 18-month follow-up noted episodes of diarrhea in their symptom diaries. Only 3%, though, had to withdraw therapy because of diarrhea. There were 24% of patients, however, who temporarily suspended their dosing with linaclotide or lowered the linaclotide dose due to diarrhea. No diarrhea-associated serious adverse events were reported throughout the duration of the trial. And interestingly, there was no impact of these episodes of diarrhea on the patient's self-reported satisfaction with therapy. If you look at that satisfaction with therapy as shown in this bar graph, among the patients who had diarrhea shown in the darker bars versus the patients who never reported a diarrhea-related adverse event, there's really no difference in satisfaction. And arguably, the patients who had had some episodes of diarrhea reported numerically slightly higher rates of satisfaction with therapy. So I think even though diarrhea can be an adverse event of therapies for constipation, over 2 years of follow-up, this doesn't see an impact on patient satisfaction. In fact, it's really not a surprising adverse event given the mechanism of action of linaclotide and other therapies for chronic constipation, and also specifically here for IBS with constipation. So I think to wrap up, we've seen some interesting news from ACG and UEW. The abstracts I've shown you relate to the diagnosis of IBS. They relate to our diagnostic approach to dysphagia with high resolution versus conventional manometry. We've looked at the efficacy of biofeedback for treatment of rumination syndrome. We've had some questions, I think, from a new clinical trial about the efficacy of low FODMAP diet as a one-size-fits-all solution for patients with IBS. And we've got some new data on the efficacy of Prucalopride and linaclotide for chronic constipation, and also of linaclotide for treatment of IBS with constipation. So thanks for your attention. We'll turn this over now to our next speaker.